I'm presenting today's clinical meeting on behalf of Medicine Unit 1. My presentation is titled Don't Be Rash. So the history is a 22-year-old lady from Assam who was a student and who dropped out of school later. She's been at home for 2 years now. She presented with a linear silvery rash over her entire body. She said that her skin spontaneously breaks and bleeds from all these sites, and it heals with this linear silvery rash. This has been happening since 3 years. Other significant history is she has history of abdominal uterine bleed, and she's been having bleeding PV every day for the past 4 months. And she had underwent a left ovarian cystectomy in 2020, and for some reason they also took out her appendix at the time. That indication was also abnormal uterine bleeding, and the histopathology showed a complex ovarian cyst. So these were the rashes that she had over her entire body, these linear rashes. It was present over her face, over her tongue, over her arms, torso, legs, everywhere. Some of them had this brownish and reddish hyperpigmentation as well. Quickly to look at what causes linear lesions in dermatology. Many of them are along bodily structures like Blaschko lines. Rashes that follow Blaschko lines are like incontinentia pigmenti, nevoid hypermelanosis, and linear FDs. Lesions along blood vessels are varicose veins, thrombophlebitis, IV drug-induced hyperpigmentation post-cancer chemotherapy. Lesions that follow lymphatics are most classically acute lymphangitis, but also atypical mycobacterium, Sporothrix schenki. Then lesions that are predisposed to following the Kebner phenomenon, like herpes zoster, vitiligo. There are auto-inoculation, that is, if you scratch along a wart or molluscum, then it will inoculate along the line of your scratch. And external factors like dermatitis artifacta, which means you make these lesions yourself, cutaneous larva migrans, the burrows of scabies. So because it didn't fit, her lesions actually don't fit any particular anatomical, they're all oriented in different lines. So we can't narrow it down to any of these. So the other rarer linear lesions in dermatology are serpentine rash and flagellate rashes. So of the lot, hers looks most similar to a flagellate rash. Flagellate rash is the one that is in the lower picture, and serpentine is the one which is in the above picture. Now, flagellation is usually most commonly seen as part of torture, sexual pleasure, abuse, and dermatitis artifacta when people do it to themselves. Other classically described flagellate rash, one is the bleomycin-induced flagellate rash, which is like whip-like lesions which involve the mucosa also after bleomycin treatment. Another disease which is important to us, which causes a flagellate rash, is dermatomyositis, usually seen with other factors, other cutaneous manifestations of dermatomyositis like the Gottron papules and heliotrope rash. Shiitake mushroom ingestion, that is raw shiitake mushroom ingestion, is also associated with the erythematous flagellate rash over the torso. So we asked her further questions, and she said that she has periorbital swelling and an erythematous rash, with itching that occurs once a year. That has been happening for the past 3 years. She also denied that she committed these lesions herself and denied that others committed them to her. So this is the erythematous rash, which looks like a heliotrope rash that she had given us a photo of. She denied any weight loss, loss of appetite, nighttime fevers or sweats, denies difficulty squatting or lifting her arms overhead, no breathlessness, dry cough, exertional intolerance, no exposure to raw shiitake mushrooms or jellyfish. On examination, she was thinly built. Her pulse was 80 per minute, regular. BP was 100/70. Respiratory rate was normal. She had this flagellate rash over her entire body and tongue, but her mid-back was spared. There was no Gottron papules, no Scholl sign present. Currently, there was no heliotrope rash either. Thyroid examination was normal. Her CVS examination, RS examination was unremarkable, and her CNS examination, her MMT-8 score, which is a score used to test for proximal myopathy, was normal actually. It was 80 on 80. There was no neuropathy. Basic blood investigations didn't reveal any gross abnormalities. We had anyway sent an ANA and a myositis profile as well. Both of them are awaited. So basically in our patient, dermatitis artifacta is still a strong possibility because her mid-back, which is the only region you can't reach yourself, was spared. but she didn't show other features of dermatitis artifacta like lesions that were predominantly on the non-dominant hand. She had equally inflicted lesions. But first, before saying that it is dermatitis artifacta, we have to rule out cutaneous dermatomyositis and cutaneous lupus as well. So there is a entity called clinically amyopathic dermatomyositis or dermatomyositis sans myositis, which means there is no clinical muscle weakness and only cutaneous manifestations. This is further classified into hypomyopathic dermatomyositis, which means the EMG will pick up some weakness, and amyopathic dermatomyositis, which means the EMG also does not pick up any weakness. Post-myopathic dermatomyositis is when the patient had myopathy along with cutaneous manifestations and you have treated them with immunosuppressive therapy and the myopathy is resolved, but the cutaneous manifestations are still persistent. A close mimic is cutaneous lupus erythematosus. Thus, we sent the ANA. Patients with clinically amyopathic dermatomyositis might still have malignancy and systemic disease, despite the fact that they don't have muscle involvement. So further evaluation on all fronts is required for this patient. They are actually at increased risk for lung disease and internal malignancy as compared to the patient who has myopathy. So my learning points are linear dermatosis and in particular flagellate dermatosis and clinically amyopathic dermatomyositis. Thank you.
Could it be due to vitamin C deficiency?
Vitamin C, yeah. Next comment. Bleeding, I don't know if it causes these linear rashes. I can have mucosal bleeding, but I don't know if it leaves this linear scarring. I'm not sure. I need to check.
Can the lesions of amyopathic dermatomyositis like come and go like that once a year? Or SLE for that matter?
Might not.
May not be. No? Amyopathic actually lab will be normal only. The diagnosis is based on the skin lesions and EMG also will be normal. But 4 or 5 years later, they may develop muscle weakness. That's why we have to keep them on follow-up. But I'm not sure whether it comes and goes like that once a year, the skin manifestations. Anybody else has any questions? Okay, shall we move on to the next presentation? Next presentation.